The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast.
Hello, everyone, and welcome to the Washington Manual of Surgery podcast. We bring you everything you need to know about the high-yield general surgery topics built for your just-in-time learning. On this episode, we are thrilled to welcome Dr. Sarah Buckman here to review all things critical care.
Thank you so much for having me today.
Dr. Buckman is a former pharmacist and current surgical intensivist at Washington University in St. Louis. My name is Adrienne Visani, and I'm a general surgery resident here at WashU, and I'll be your host for this episode. In this episode, we will cover some common issues in the care of our critically ill patients. Let's start with a case to guide our discussion. For our first case, you are in the ICU taking care of a 64-year-old woman who is post-operative day 2 from a total abdominal colectomy and end ileostomy for fulminant C. diff colitis. The patient has a past medical history of coronary artery disease, atrial fibrillation, and diabetes. She develops chest pain and palpitations with a heart rate to 140. Dr. Buckman, what else do you want to know about her?
Well, this is a very common patient we take care of in our unit. Her comorbidities and perioperative fluid and electrolyte shifts place her at risk for arrhythmias. I'd first want to rule out sinus tachycardia because that would be treated very differently. I'd also like to know her other vital signs and her fluid status.
Okay, so her other vitals are normal. She's had 2 liters of output from her stoma today and low urine output. You obtain an EKG, and it shows supraventricular tachycardia. How might you approach management?
Given that she's hemodynamically stable, we have time to try medical cardioversion, specifically adenosine for SVT. I'd start with 6 milligrams IV push with a normal saline flush very quickly, with a second bolus of 12 milligrams if the patient does not convert to normal sinus rhythm within a few minutes. I'd also give fluid and correct any electrolyte abnormalities. Potassium is one of the biggest culprits, especially given high-volume GI losses. It's also important to have appropriate monitoring in place. This patient should have an arterial line, a Foley catheter, and durable venous access.
So let's say instead the tachycardia was sinus. What would you be thinking about in this postoperative patient?
For someone who just underwent a total colectomy with high fluid losses, dehydration and abdominal sepsis would be high on my differential. Fluid resuscitation is important, as always, in sepsis. I would use my lab values and other vitals to help guide me. In addition, point-of-care ultrasound is a good tool to assess fluid status quickly. As sepsis is a possibility given her recent operation, I would obtain cultures and avoid overly broad antibiotics given her recent C. diff colitis. It's important to consider the contribution her coronary artery disease and the possibility of reduced cardiac function in a patient with her clinical condition. I would check troponins in EKG and obtain a comprehensive transthoracic echocardiogram to assess for wall motion abnormalities. If we suspected cardiogenic shock, inotropic support in addition to non-invasive cardiac monitoring or even floating a PA catheter to monitor cardiac output would be utilized. And mechanical circulatory support technologies such as an intra-aortic balloon pump, Impella, and even ECMO are important adjuncts to keep in your back pocket for those patients refractory to medical management.
So let's say you've successfully managed the SVT and provided adequate fluid resuscitation, but on the following day, the patient has a bump in creatinine from 1.8 postoperatively to now 3.7.
This is very common. Perioperative hemodynamic and fluid shifts certainly set this patient up for reduced renal perfusion and thus acute kidney injury. Don't forget to consider post-renal causes as well. This patient should already have a Foley for decompression, but upstream obstruction is possible, especially in the case of retroperitoneal dissection where ureteral injury may have occurred. I would check the medication list and discontinue nephrotoxic medications such as vancomycin, aminoglycosides, NSAIDs, and diuretics, and make sure all others are renally dosed. Finally, remember your indications for renal replacement therapy: acidosis, electrolyte abnormalities, intoxicants, overload such as fluid, and uremia. In critically ill patients, dialysis most often takes the form of continuous renal replacement therapy, or CRRT, which minimizes the hemodynamic shifts associated with traditional intermittent hemodialysis.
Okay, so let's say this patient is started on dialysis due to significant oliguria and acidosis. As her post-op course continues, we need to start thinking about nutrition. How would you approach this?
In her case, her ostomy is productive already, so we presumably can begin enteral nutrition. Enteral nutrition is preferred to parenteral nutrition in critically ill patients. If patients cannot take food by mouth for any reasons such as intubation, neurologic, or other reasons, we often start with trickle tube feeding either into the stomach or post-pylorically via a feeding tube. Adequate protein is critical for healing postoperatively, though nitrogen balance is also important to consider during renal recovery. If the gut cannot be used, we aim to initiate total parenteral nutrition within 5 days to a week of patients with no or suboptimal nutrition. For patients that are severely malnourished before their operation, we may initiate TPN earlier given the importance nutrition plays in the postoperative course. Important risks to consider of TPN are bloodstream infection and liver injury from cholestasis.
In a similar vein, no pun intended, what are the takeaways from the literature about glycemic control in critically ill patients?
According to the NICE sugar trial, adult ICU patients randomly assigned to the conventional glycemic control arm with a blood glucose target of less than 180 had lower mortality than those assigned to a more intensive target of 80 to 108. Severe hypoglycemia was much more common in this intensive control group, as you can imagine. The takeaway was that targeting a lower glucose level with intensive insulin therapy does not necessarily benefit and may actually harm patients.
Thanks so much for walking us through that case. Let's move on to another patient. This time, you're in the emergency room, and a 27-year-old male comes in after a motor vehicle accident. He arrives hypotensive with a heart rate of 65 and a GCS of 15. You suspect a high cervical spine injury. Dr. Buckman, what would you be thinking about first in terms of addressing his hypotension?
This is another good case. You should always consider neurogenic shock in patients with fracture dislocation of the cervical spine. Patients may have immediate loss of all spinal cord function and reflexes below the level of the injury, or they may progressively develop symptoms over hours as spinal cord edema progresses. This can include loss of sympathetic tone, leading to the classic triad of hypotension, bradycardia, and peripheral vasodilation. Severity of cord injury is classified by the ASIA scale, with sensory function often being preserved except in very severe injuries. Cervical spine stabilization is critical in preventing progression of the injury.
Are steroids still recommended in spinal cord injury?
Steroids are no longer recommended due to lack of evidence that they provide a benefit.
Okay, so we know blood pressure support is critical in preventing secondary ischemic injury to the spinal cord. What are some management pearls here?
We usually aim for MAP goals of at least 85 to increase spinal cord perfusion. Dopamine and other pressors with inotropic effects such as norepinephrine are first line in neurogenic shock patients with bradycardia, as bradycardia is also a key sign to determine neurogenic versus other type of shock in these patients. Keeping these patients warm is also key given their profound peripheral vasodilation.
So in our scenario, the patient had an isolated cervical spine injury with a GCS of 15, but these patients also frequently have concomitant traumatic brain injury. What are some of the things you want to keep in mind in that scenario?
Immediate medical management should also focus on minimizing cerebral edema with head of bed elevation, osmotic diuresis, maintaining normothermia, and sedation. We consider placement of an invasive ICP monitor in patients with a depressed Glasgow Coma score who cannot participate in serial neurologic exams. When patients with severe TBIs are in the ICU, we treat neurostorming episodes with temperature control and medications such as beta blockers, specifically propranolol that cross the blood-brain barrier, clonidine, bromocriptine, and GABA agonists such as gabapentin. In those patients that are receiving continuous sedation such as fentanyl and propofol, we can also administer boluses of those medications. In severe cases, we will try chemical paralysis and also discuss with our neurosurgical colleagues the conversion of an ICP monitor to an EVD for CSF drainage, and as a last resort, decompressive craniectomy.
Thanks. So back to the scenario where there is no head injury. With an isolated C-spine injury and compromised innervation to the muscles of respiration, what are you thinking about in terms of ventilatory support?
We think about early endotracheal intubation in a lot of these patients, especially with higher injuries. Sometimes this will happen in the trauma bay. In any case, we use rapid sequence intubation with these patients because we don't know their NPO status. To mitigate aspiration risk, we also try to avoid bake mask ventilation prior to intubation, but we can pre-oxygenate with other adjuncts like high-flow nasal cannula. Cervical spine stabilization is critical during intubation.
Once the patient is intubated, Dr. Buckman, how are you managing the ventilator?
It definitely depends on the mechanism of injury. If the cervical spine injury was sustained during a diving accident, for example, concomitant fluid aspiration can lead to ARDS, in which case we put special emphasis on lung protective, low tidal volume ventilator strategies and may consider adjuncts like proning. All mechanically intubated patients should have spontaneous awakening trials and, if possible, a spontaneous breathing trial every day. Unfortunately, for most patients with a very high cervical spine injury, they will need prolonged ventilatory support. At our hospital, we have an early tracheostomy protocol for patients with a C1 through C3 injury. For patients with C4-5 injuries, especially without concomitant or underlying lung disease, we consider a longer ventilator weaning period with bronchoscopy and extubation trials before going forward with tracheostomy.
Great. That wraps up our second case. Thank you so much, Dr. Buckman, for being with us today. We got through a ton of great information about critical care.
Thanks so much for having me. This was great.
And as always, if you're looking to learn more, you can check out some of the literature we referenced in today's episode in the show notes, and a full review of critical care can be found in the Washington Manual of Surgery.
We are Drs. Paul Wise
and Jeff Platnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams & Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.